Good day, everyone, and welcome to today's webinar entitled Connecting the Dots, How to Achieve a Comprehensive and Holistic View of Risk in Healthcare. My name is Mark Hagelin, and I'm Editor-in-Chief at Healthcare Innovation. Today's program is sponsored by Salesforce App Exchange in concert with Riskonnect. Thank you so much to our friends at Salesforce App Exchange and Riskonnect, and to you and our audience for giving us your time and attention today. Before we get started, I have a few housekeeping details. To submit a question, please use the Q&A box to the left of your video window at any time. You do not need to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag #HILiveWebinar. And at this time, it's my pleasure to introduce our speaker for today's program, Jay Lechtman, who is Vice President, Strategy and Innovation, Healthcare at Riskonnect. And I'm going to have him say a few words about himself to our audience. Jay, welcome. Great to be with you today.
Thanks, Mark. Likewise. So a little bit about myself. I started my career as a journalist, writing and editing for mainstream newspapers and specialty magazines. In healthcare, I started in publishing, medical coding and reimbursement, which then expanded into managed care compliance, and ultimately patient safety, patient satisfaction, and clinical quality and risk management. I've had similar strategy and innovation roles for other software companies, but I was attracted to Riskonnect because it was built on a technology platform that made it very easy for me to actually help execute all of the great ideas I wanted to accomplish.
Wonderful. Well, you're the perfect person for today. So thank you. So let's dive right in and talk about this really, really interesting topic. It's very, very complex. Let me ask you first, Jay, why do you think it's the case that provider organizations in healthcare are struggling to connect their traditional risk management efforts to enterprise risk management initiatives? Isn't enterprise risk management supposed to be comprehensive?
That's a great question. And here's where my journalist background kicks in, whether I want it to or not. I look at the term enterprise risk management and I think about what those words mean on their own, without context. It means managing risks across the enterprise. You can be managing all of your risks in your organization, but that doesn't mean they're not in silos. That doesn't mean they're not disconnected and not interrelated or technologically interoperable. So you can be practicing enterprise risk management, but not really, at least in my opinion, living up to the full potential that integrating that comprehensive risk management view should be able to provide. And I think there are a couple of reasons for that. ERM, enterprise risk management, is comparatively new to healthcare. It's been practiced in financial services and in other industries around the world for decades. In healthcare, it really started, at least in a formal way, with its introduction by the American Society for Healthcare Risk Management, or ASHRM, in 2014. So here you had a new risk concept that was being positioned to a very well-established, well-entrenched clinical risk management audience, also called insurable risk management, traditional risk management, and for good or bad, I would argue not necessarily to the good, many of these ERM initiatives, because they were new and because clinical risk management was already fully focused and fully tasked with its areas of responsibility, ERM was often initiated out of the compliance department and often tied to issues like information security or legal or even finance. So in many cases, in my observation of healthcare provider organizations as they began their ERM journeys, they were unfortunately creating a second new silo. You had one silo, which was traditional or clinical risk management, and you had this new silo that was being created. around strategic, financial, operational risks. Now, in full transparency, there can often be some representation of clinical risk management on these ERM steering committees, but often that's a token presence. Often those who are really driving the ERM initiatives in healthcare don't have a full understanding about where clinical risk management, traditional risk management, fits in.
I think that's so interesting, Jay. I have to say that this kind of reminds me of everything else about healthcare, which is that everything is disjointed, balkanized, siloed, and so often the key people who need to sit around a round table, we're missing people at the table, right? And the discussions tend to be so fragmented because
Exactly.
healthcare is fragmented. Yeah, exactly. Now, how might technology be exacerbating a part of this challenge?
So if we go back to that organizational model that I painted a moment ago, you have these functional silos. You've got safety, and to the point you just made about the disjointedness of so many initiatives in healthcare. You've got these functional silos. You've got patient safety. You've got patient compliance, patient satisfaction, patient experience, whatever you call it in your organization. You've also got provider quality management, peer review, ongoing professional practice evaluation, you've got credentialing, you've got compliance. So you have these functional silos even within traditional risk management, plus the new silos around enterprise risk management. And wherever you have functional silos in an organization, not just in healthcare, those functions typically have their own technology stacks as well. So you've got both operational and technological silos. You've got data silos as a result. And whenever you're trying to do analytics on that siloed data, the analytics capabilities are often only able to focus on the data that's within their stack. So you may get great analysis of these individual areas, but you have no automated or facilitated way to the title of the presentation, connect those dots to understand how they work together and how one of those risk areas can impact or be impacted by another. We have close to 180 healthcare provider organizations as clients, and I spend time with as many of them as I can. The average provider organization has between or had between 5 and 15 different systems for all of those risk, safety, quality, compliance management activities that I just mentioned. And few, if any of them, were designed to work well with each other, to share data, share functionality, share workflow. And in many cases, they come from different vendors as well.
Wow, that's just really, that's very tough. In a strange way, it reminds me, if you watch these nature programs and learn about honeybees and how they're in very specific roles, except the difference is that the hive works overall, yes. And healthcare sometimes doesn't. So if technology is a part of the problem, Jay, how can technology help to solve it?
Well, you talked a moment ago about how disjointed healthcare can be, and I agree. In the worst examples, it certainly can be. But on the positive side, healthcare, at least in terms of technology, has a great model for what I'm talking about. It's the EHR. Thanks to meaningful use and other initiatives, both public and private, most organizations have standardized on one or at least a few enterprise EHRs. They may have one for inpatient, one for ambulatory. They may have acquired facilities that have their own EHR, but I don't talk to anybody in healthcare that says they're looking for more clinical systems. They're looking to consolidate, they're looking to aggregate, they're looking to do as much as they possibly can on a single EHR. They look to it, and rightly so, as a single source of truth for clinical information. Whether that data, that information is created organically within the EHR or it's integrated with other data sources. So you've got both the organic creation and management of clinical data through transcription and the automation of the patient record. But you also have the concept of interoperability, which, while not perfect, is certainly stressed and is absolutely a goal for EHRs, not only to work with other clinical systems, lab, radiology, and the like, but also to communicate with other EHRs to create the population-based single source of clinical truth. That's a model that other functional technologies within healthcare can, and I would argue should, model themselves after.
Yeah, absolutely. I mean, it's the complexity of process in healthcare is just stupefying at times. And if we can attack some of those process issues, I think that's...
Yep, absolutely. Just like with the EHR, the right technology can create a single source of truth in parallel for all things risk, quality, safety, and compliance. The same kind of model, the same kind of benefits, greater efficiency, greater accuracy, and certainly greater transparency.
Yeah, absolutely. That's the dream. Could you walk us through perhaps a real-life example of what integrated risk management looks like in healthcare? What is that creature? What does it look like? A giraffe or a zebra or a kookaburra?
It reminds me of a joke my European friends tell me. Anytime Americans talk about something like an asteroid that is risking, a strike on the Earth, it's always compared to something other than, dimensions. In Europe, this is how many meters long and wide that asteroid is. In America, the media always says it's as big as a giraffe or as big as an elephant or as big as a house. So it doesn't look like a giraffe. What I'm going to do is give what I think is probably a very simple, very basic, almost too basic forehead slapping example, but I've used it or something similar in other conversations, and it seems to drive the point home, perhaps because of its seeming absurdity. Every hospital has an environment of care staff. They've got housekeeping, they've got engineering, they've got dietary and security. Likely they've got perhaps one for all, perhaps one for each of those functions, a ticketing and dispatch system to solve operational problems. A leaking roof is leading to several areas of wet floors. Patient safety also has a system. It's an incident reporting system that's designed to capture patient slips and falls, along with lots of other adverse events. Now, wet floors can obviously be a causal or contributory factor to these falls. Some patients may have slipped on wet floors but weren't injured, and some commendably vigilant staff may have reported the wet floors into the system on their own as unsafe conditions that could potentially lead to safety events and patient harm. Now, if I connected those two systems, I increased the likelihood that I can identify which of those wet floors has the highest risk of impacting patient safety, and as a result, elevate the urgency of those wet floors for correction. So they get fixed immediately and in priority order compared with everything else. The dispatch system normally would have no visibility into the patient safety impact of its actions. And the patient safety system would normally not be able to automatically trigger a priority response in engineering or housekeeping. It normally would have taken a manual effort, an email, a phone call, a hallway conversation to make that connection. So if I can inform the dispatch system with the patient risk propensity, I can change the first in, first out ticketing process into one that focuses on the improvements, the interventions that have the greatest opportunity to reduce patient harm. That's just one, as I admitted at the beginning, very simple, specific example.
That's terrific. What do you think is the best example you've seen so far of true integrated risk management in healthcare?
So one of our clients is a large Midwestern academic medical system that to its credit, is in the process of leveraging our integrated risk management solution to facilitate a complete redesign of their overall safety and risk management structure. They're organizing it around three core principles or constituencies: their patients, their providers, and ultimately the institution as a whole. They are building comprehensive visibility around each of these three so that they can better manage them in real time, as well as ultimately understand the relationship between those stakeholders and how they interrelate, how they impact each other.
That's terrific. I mean, and that's where we should all be rowing towards together, right?
I think so.
Yeah, exactly. What do you think other provider organizations can learn from what they're doing?
In a word, or actually two words, think big. Like this example I just gave, they should be thinking big in terms of ideas around risk, big in terms of the capability and flexibility of the technology they use to manage those risks. Going back to that EHR example, one solution, one platform can combine risk identification with all of the operational activities that identify, prevent, mitigate, or clean up after these risks, is a much better way to approach this than trying to cobble together those up to 15 different solutions in an attempt to do the same thing. Now, our solution is integrated risk management, but our partnership with Salesforce is giving our healthcare provider clients an even bigger opportunity, we think, to integrate our integrated risk management with the patient and provider relationship management solutions that they provide. We are having conversations with joint client partners about how risk data can inform the agents that are answering their call, their organization's call centers, how understanding the past complaints or grievances, the past safety incidents, even the past claims and lawsuits of a given patient can help drive better decisions about which specialist that patient should visit or what activities should be engaged in to ensure patient satisfaction proactively before they even arrive at the facility or at the ASC or at the clinic for the appointment they made through the call center, so that we really can provide an end-to-end solution that connects the risks with the activities, with the workflow that are designed to prevent those risks ultimately from happening, or certainly reduce their likelihood in terms of frequency and severity if they do happen.
That's terrific. That's clearly one of the lessons being learned out there. What are a few of the other lessons being learned on this journey? Because it seems to me this is definitely a journey, right?
Yeah. So what our clients, what providers we've observed are learning are, there really are significant operational benefits from implementing integrated risk management, whether they're doing that on their own or they're doing it with an enabling technology solution. The practice of thinking holistically, how to connect leading indicators to potential risks has enormous benefit. Healthcare has learned from a lot of other industries. They've adopted best practices from manufacturing, from aerospace and defense, from the hospitality industry, but I do work primarily with healthcare providers, but I also have had an opportunity to work with Riskonnect clients that are outside of healthcare, in retail, in manufacturing, and in other industries. Healthcare does a much better job, frankly, of at least trying to prevent incidents from happening, learning from those unsafe conditions, those near misses that I talked about earlier, and adapt that learning to interventions that reduce the risk of those actual risks from happening in the future. A lot of other companies, including very large companies that have household names that I won't mention, are very much in the get a claim, pay a claim mindset. They don't focus on reducing the actual events, the actual risks. What they do focus on is trying to make that risk management, that claims and litigation management process, more efficient, less expensive. I would argue if you're focusing on prevention, your risk and claims management process is going to get cheaper all by itself because you're going to have fewer of them that need to be managed. So that understanding that connectivity really is a significant operational improvement, as well as the ability to monitor those interventions in real time to ensure that they're effective once they're implemented, but also sustainable over time. I hear from lots of organizations, I make these changes, I do these action plans, after a peer review, this physician is tasked with X, Y, and Z, but I don't really have a good way to understand whether that worked or not until the next adverse event. So part of holistic integrated risk management is understanding how to evaluate those interventions and to adjust them in as close to real time as possible to make sure that they're working from the outset and that they continue to work through staff changes and policy changes and the like.
And this speaks to the issue or question of operational improvements. It also, to me, speaks a little bit implicitly to financial benefits. So can you share a few operational improvements that providers are experiencing now after implementing integrated risk management? And are there financial benefits as well? And can those be quantified?
Yes. So, we've talked just in the last few minutes about, many of what I think are the obvious, or at least the initial operational benefits. And, unfortunately, there has been this perception in healthcare safety, healthcare improvement, that these interventions can be very difficult to quantify. Every time I go to an industry event around patient safety or around healthcare quality, there's always at least one session on how do I quantify this? How do I convince my CFO that these investments are worth making when they're such soft things? And I think that really is a perception. I think it can be a misperception if the data exists to show the financial return on these kinds of interventions. The challenge, which goes back to connecting the dots, is financial systems are typically not integrated with safety and risk systems. They are to the extent of having to cut a check for an attorney, or to cut a check to settle a claim, but not in terms of trend analysis around what is my reduction in risk and claims liability costs, not only the cost of the lawsuit judgment or the claim settlement themselves, but also all of the work, both internal and external, to manage and defend manage those claims, defend those lawsuits. But by connecting the dots with financial trend data, you can quantify what those savings are based on trends in on trends in frequency and severity of incidents that are avoided through better risk management. And to try to prove that, we actually engaged an industry analyst, Forrester Research, to try to identify the quantitative benefits. One client, 3 years after implementing our IRM solution, saw nearly a 300% return, a 280% return on its investment, which for this organization was nearly $1.8 million net of all costs. Now, obviously, every organization is different, and I'm not suggesting that this kind of cost savings is going to be the same for providers of every size, but we expect the composite savings components to hold true, more or less, across all kinds and sizes of organizations. This client saw two major areas of savings. The first was a 55% increase in efficiency due to the automation of manual tasks, and another 55% or so savings from improved risk avoidance. Using that new transparency to identify where to make the right risk management investments, to yield the maximum impact on performance improvement and the greatest reduction in liability and related costs.
I really love that leaders are working to quantify the savings from avoidance. You know, so often we want to avoid or avert a hospital readmission, for example. There's a mandatory readmissions avoidance program under Medicare. Just say a couple words about that, because I think so often in healthcare, we want to be able to say something like, and this is how C-suite members think sometimes, if we get a new PET CT scanner, based on the volume of diagnostic scans done, it will add, 1.2 million to our bottom line revenue figures, right? When you engage in avoidance, which you must do in these areas, it can be a little bit difficult to quantify that and to prove that you've quantified it. But how are those who are presenting to the C-suites becoming more successful in quantifying avoidance?
Sure. And those are both great examples. I mean, everyone's focused on 30-day readmissions because there's a financial penalty associated with them. So there's a real cost to an unplanned readmission. And likewise, to your point about the diagnostic scanner, it's easy for a CFO to understand what that costs, acquisition and maintenance and related staff increase costs, and they can see what they're going to get in terms of profit for every scan that's done. But to this concept of avoidance, it's easy to think about readmissions in the clinical sense, but a lot of preventable patient safety errors can also lead to readmissions. And patient safety errors include things like incorrect or delayed diagnoses. And that, again, one perhaps simple example, my guess is that the CFO, when they're thinking about buying a new scanner, they're not necessarily thinking about how many diagnostic related errors are they receiving through patient safety and risk management? What are they paying out in claims and litigation judgments because a patient's cancer was missed, or an endoscopy didn't necessarily show that a polyp was cancer instead of merely precancerous? Could that diagnostic scanner, because of improved technology, reduce the number of diagnostic related errors? Could preventable disease or treatable disease be identified earlier and with more accuracy? That can easily flow into that value equation, that financial equation, if the data's available and if it can be presented in a way that makes financial sense as part of that overall decision-making process. But without being able to connect those dots, that data is typically completely separately managed and would not enter into a decision like that. And that could easily sway the decision to buy the scanner as opposed to waiting for another year.
Yeah, absolutely. So per that, how are risk managers in patient care organizations helping to convince the C-suite executives that integrated risk management is indeed the way to go and that they can benefit from it?
Sure. So the EHR example I gave above is a very useful tool. It's a great shorthand, particularly with clinical leadership within the C-suite, the CMO, the CMIO, the CNO, the medical staff executive, to understand the problem of disconnected systems for safety, quality, and risk, and look to an already proven solution model, the EHR, for a way to improve this. And it goes beyond the clinical, although in my experience, they're often very early adopters and advocates for this integrated risk management model. I mentioned up to 15 different solutions from different vendors. Consolidating those solutions does more than just improve risk performance. It can also reduce the cost and complexity of the IT support required, as well as eliminate a number of third-party vulnerabilities to cyber attacks. that's a message that both the CIO and the Chief Information Security Officer can get behind. And the related cost savings of reducing that complexity and that associated cyber risk should appeal to the CFO as well.
Absolutely. And if there's one thing that you would like to share with risk managers in healthcare, so that they can create a holistic vision of risk management, what would you share with them?
Well, I would start by probably sharing the recording of this presentation so they can refresh their memory before they go in to talk to their leadership about perhaps a better way to do this. And obviously it depends on what their circumstances are in their organization to begin with. I know that traditional risk managers are looking in many cases to enterprise risk as a way to advance and expand their careers within healthcare, their advancement potential, and career satisfaction potential. They don't want to be relegated to what's seen as the old risk management. And so they need to advocate, if it's not already happening, for this integrated risk management model, because it, by definition, ensures that clinical risk management has a material seat at the table, probably several seats at the table, when an organization is looking at enterprise risk management in this integrated, holistic way. And they have a unique opportunity to tell the kinds of stories that I've just touched on in this session, about how a better understanding and integration of those clinical risk data elements can really inform so many other areas of the organization, ultimately to organizational and performance and financial improvement.
Wonderful.
It's a big task. I've suggested that they need to think big, but this big thought can have huge rewards, not just for them individually and professionally, but also for their organizations.
Yeah, absolutely. Absolutely. So we have a question from the audience, Jay, and that is, where should healthcare organizations start if they're engaged in enterprise risk management and want to evolve it into integrated risk management?
So I would go back to the conversation topic suggestions that I made a moment ago. They should understand where they see the gaps. When they look at all of the materials that have been produced in their organization around this ERM initiative, really analyze it objectively and critically. Talk to their clinical risk management leadership, if they're not already, about where they see this could be improved and what the specific, at least some of the specific benefits could be. It's really a gap analysis and a recommendation of what should the trajectory be instead to really achieve the kind of benefits that I've touched on that I think everyone in healthcare can understand and appreciate.
Yeah, wonderful. Well, I want to thank you, Jay. Do you have any closing thoughts? That you've enlightened us so much on this, and I've learned so much about how we really have to be thinking at a high strategic level. But do you have any closing thoughts that you'd like to share with us, words of wisdom for our audience as they consider what to do next?
Sure. If they don't know where to start at all, and they really are looking for where to begin or what those first steps should be, I mentioned ASHRM earlier, the American Society for Healthcare Risk Management. They have a great ERM playbook. It does talk about comprehensive risk management, and it integrates with a non-healthcare organizational framework called COSO, which really provides sort of the organizational framework, the process framework for how to go about an ERM process. The only thing I would ask them to keep in mind is ASHRM doesn't explicitly talk about the interconnectivity, the integration of risk management. And as I hope I've convinced those who may not have been otherwise after today, that's critical to success. You can do, as I said at the beginning, ERM without really doing ERM.
Yeah, absolutely. So I believe we have one or two other questions, but I am struggling to find them inside the. Oh, here we go. I'm sorry. There were a couple others. My apologies, Jay. Here's one. Can you differentiate your view on organizational risk management from the application of total quality management and Six Sigma methods? That's kind of interesting, right?
So I could take the easy way out and say integrated risk management shouldn't be differentiated from anything and not have to speak about TQM or Six Sigma. But in all serious, or at least primarily serious, I mean, Six Sigma is efficiency. And I have heard directly from healthcare providers after implementing solutions like this, or at least initiatives like this around integrated risk management, that they have achieved, in their own words, Six Sigma level of confidence around their reduction in preventable errors. Now, this was in a pharmacy environment, but pharmacy is healthcare and certainly can be complicated, and medication errors are, if not the most frequently reported adverse event in healthcare, they're certainly very close and probably neck and neck with slips and falls. So quality management is part of reducing patient-related injuries, patient-related complaints and grievances, and the interaction of providers and other clinical staff that are being analyzed and managed and sometimes corrected or even terminated under provider quality because of their potential impact, positively and negatively, on those two areas I just mentioned, patient safety and patient satisfaction. So, you know, to quote the old New York telephone ad, which is somewhat dating myself, they're all connected. They all are interrelated.
I remember that ad, so we're at least the same age. And we have a question. I'm going to kind of read it fast because the audience member says you already addressed a piece of this. So I'll read this a little bit fast. The first part of the question, the audience member says, if we have what you described, which is a balkanized, disjointed, siloed technology, and the only next step is considering technology, does that alone provide an integration? Is there anything else an organization can do that would provide similar benefit? And then the audience member says, I just heard Jay provide an answer, which is to think about operational issues like focusing on claim prevention. Is there anything else that you can share, Jay?
So while I would love everybody to buy our software, I'm not in sales. I know that's not a practical suggestion. You can certainly do this without a fully integrated technology. It's not going to be as easy, and ultimately I don't think it's going to be as effective, which is why we developed this single platform integrated technology. The key is interoperability. If you can take those 15 different systems and they can produce spreadsheets, and you've got a clinical data repository with a good business intelligence solution that can take that data, you can start to look at the data in relationship, but it's not going to be automated. And there's a lot of manual sort of massaging of that data, normalizing of that data in order to make it consumable for executive leadership. I'm not saying it's impossible. And one thing I hear along similar lines is, well, we're not going to tear down all of these silos and suddenly become a fully integrated organization. And I totally agree. I've never seen a silo be effectively dismantled. At best, it sprouts up somewhere else, or the disappeared silos reform into new configurations. You know, the example I gave earlier, the two silos in healthcare now, ERM and everything else risk, is an example of that. But the right technology, whether it's ours or somebody else's, can dive into each of those silos and grab the data it needs. It can connect, it can be the connective tissue between those data silos, and it can look between those silos for how they should or could be correlated, how they could be related to answer some of the business questions, the clinical questions that I've raised here. It can be done. What I do say, what our company does say when organizations say, do we have to buy new software, and isn't that going to be a huge added expense? I would go back to the point I made around the CIO and the CFO example. I would argue, although we haven't done the kind of analysis we've done on the financial return around this, that your IT department will save money managing one system from one vendor rather than 15 systems from 15 vendors. If you leave the cyber risk out of it, you just look at the IT burden, it not only is it going to be better operationally for the organization as a whole, but it's going to be more efficient and cost effective in terms of IT support and management.
Yeah, terrific. Now, the last question from the audience you've already partly answered, so it'll feel a little bit deja vu-ish, but I'll read it anyway and you can respond as you'd like. So this audience member says, it seems that the recommendation coming out of this webinar would be just to transition to a single system such as Riskonnect. However, that is not always feasible because of the silos that have already been acknowledged. Even if there are efforts in place to consolidate systems, what recommendations do you have for leveraging the data across disparate systems in the interim?
Sure. Some organizations use spreadsheets. It's workable. It's not ideal. Some organizations, to your point, to my earlier answer, will use their enterprise data repository, their enterprise analytics capability. It may be Tableau, it may be Power BI, it may be something else, but that can ingest and look at different data sources. It's still going to rely on human intervention to make those connections if the system isn't set up to do that from its initiation in the organization, but it is possible. I would argue that leave the technology aside for now. If it's not an argument you think you can win in the short term, and given supply chain and COVID and staffing, I'm looking at all of the revenue numbers of healthcare organizations, and it is a difficult time for an industry that already has slim margins during the best of times. Just changing the thought process. Just if you can't reorganize your functional silos, making sure that your ERM committee represents all of them and that there is communication and collaboration between them. That one step, which shouldn't cost a dime, I think would at least set up your organization for greater success, or at least the greater likelihood of success in approaching the concept of enterprise risk management in this integrated way that I'm obviously advocating for here. I hope that helps.
I'm sure it will have helped. Thank you so much, Jay. Any closing thoughts?
I really appreciate the opportunity to talk to you about this. This is what I do. I'm happy to drone on about it forever, it seems. You ask my colleagues. And I truly appreciate the audience as well. The questions were great. Clearly thinking about real life practical challenges to making this work. I do the same thing. I love nothing more than helping our clients and other organizations think about how to solve this. I think it's the right way to go. I think every healthcare organization should be doing it. I want to do everything possible to help smooth the way towards that.
That's wonderful, Jay. You've been terrific today. I have learned so much. I know so many in our audience have. And so thank you very, very much.
Thank you.
Absolutely. So that is all the time we have for today. I want to thank Jay for the wonderful presentation and discussion. And I'd like to once again thank our friends at Salesforce App Exchange and Riskonnect for making today's program possible. Finally, I'd like to thank all of you in our audience for joining us. We hope you'll join us in the future for another Healthcare Innovation webinar. This concludes today's presentation. Have a wonderful day, everyone, and thank you.